Awesome. Let's go ahead and get started. Um, Hello, everybody, and welcome to the first of six in the Population Health webinar series. My name is Stefa Dragoon. I'm the Rural Population Health Program Manager at the Oregon Office of Rural Health. And today's webinar is Population Health 101, presented by Tracy Morton of the National Rural Health Resource Center. So this webinar series is really designed to establish a common understanding of population health and where we can go from here. Population health and health equity have really grown in focus over the years for many reasons, including the realization that the high level of healthcare spending in the US is not producing the value we'd like to see in terms of the overall impact on health. The healthcare industry is going through some profound changes in financing and service delivery as it shifts from a financial system based on volume to one based on value. Today, rural health organizations face the challenge of remaining viable under current payment systems while also preparing for new value-based systems that are being adopted across the country. So this series is really intended to learn together and have some of those conversations about how to approach population health moving forward. And I'm really happy you all were here to join us, and thank you to Tracy Morton for taking the lead on this webinar. So if you could go to the next slide, Tracy, thank you. So here's a list of the full webinar series, which you can register for on the website, and I'll put that in the chat for you. We do, you would have to register for them individually, so just putting that on your radar. The dates for the June and July are still in the works, but otherwise you can register for the rest of the series. And the next slide, please. Thank you so much. So I also wanted to let you know about the Population Health Grant Program that the Oregon Office of Rural Health is administering. This grant supports critical access hospitals and provider-based RHCs with addressing a specific population health need in your community. And if you go to the website, which I will also put in the chat, you can see some of the amazing projects that were funded in this past cycle. And I'm letting you know about it today because the request for proposals is going to be released on June 12th. So please stay tuned to that, and we'll put that information out in our newsletter and through social media as well. Great. So the next slide. Yeah, so Tracy has no conflicts to disclose. Just in terms of logistics for this webinar, please make sure you're muted. We will have a Q&A at the end of the presentation, so we can address questions there. You can also, at the end, raise your hand and you'll be able to unmute yourself and ask your question. You can put questions in the chat, and so we can kind of facilitate that dialogue that way. And another, just FYI, the slides and the recording for this will be posted to our website at the link that I posted first in the chat. Awesome. So with that, I am really pleased to introduce our speaker. As the Director of Population Health for the National Rural Health Resource Center, Tracy directs the development and implementation of population and community health services for hospitals, networks, and states in alignment with the center's vision to sustain and improve healthcare in rural communities. She serves as a subject matter expert on population health, strategic planning, community health needs assessments, and strategies for transitioning to value-based healthcare. Tracy has worked in public health at the state, local, and tribal levels. She received her Master of Public Health in Epidemiology from the University of Minnesota Twin Cities. Welcome, Tracy. Thank you so much for being here and sharing your expertise, and I will hand it over to you.
Thanks, Steph. I'm really happy to be here. Thanks for inviting me. A little bit more about our organization, the National Rural Health Resource Center. So that's a long title. We often refer to ourselves as the center. We're a nonprofit organization. As Steph mentioned, we're dedicated to sustaining and improving healthcare in rural communities. And as such, we're the nation's leading knowledge and technical assistance center about rural health. We do our work in the 5 key areas there on the screen, the top one being transition to value and population health, which really touches into all of the things that we do at the organization. I interact with Stefan. How I met Stefan first is through The other hat that I wear at our organization is leading a federally funded technical assistance center that works with all the 45 states that have critical access hospitals in them. So that is how I interact with the Oregon Flex program, and I'm really happy to be able to provide this information to you today. A little bit more about our organization is that we've adopted an organizational culture where diversity, equity, inclusion, and anti-racism is at the forefront of what we do, and it's how we build a culture of our organization. It's also how we show up to do our work. So we're committed to DEI and anti-racism. It creates that environment that reflects the communities that we live in and serve in. It also reflects who our staff are and how we want everyone to show up and feel accepted and empowered to be their full authentic selves. So it's present in our work, how we interact with one another and how we interact with the communities that we talk with and work with. And it'll certainly come up in our conversation today too when we talk about population health, health equity, and other items. So what we'll be covering today is I'd like at the end of the conversation today here that you can walk away understanding what population health is just as a general concept, that you can explain why a rural healthcare organization should focus on population health, recall some of the basics of value-based healthcare models, and then be able to interpret how population health relates to those value-based models and how it interacts with social determinants of health as well as health equity. So we're going to go on a journey through some of these concepts, and first we'll talk about what population health is. I am going to provide some definitions because I do think it's just kind of grounding so that we're all in the same place. I really like this definition of health from the World Health Organization, or WHO. It says that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I think two things are pretty profound about that definition, with the exception that I just think it's good and complete. One is that it was developed in 1946. So I think that's pretty profound. And I think the other thing is that here in 2023, as a country, I think in healthcare, we're still moving to this place of really understanding that health is not just merely the absence of disease or infirmity, but it's recognizing the whole person, physically, mentally, spiritually, socially, however they want to be seen for health for that individual and what that means to serve that as a country and in the organizations that we all work in. To go a little bit more into definitions, I think it's good to talk about what the definition is of population health, because I think this gets into some murky waters. We often use this definition from the American Hospital Association, and that talks about population health serving as a strategic platform to improve the health outcomes of a defined group of people. And it looks at 3 different stages. So the first is, what is the distribution of a particular health status or outcome within a population? The health status could be diabetes. It could be also individual's perception of whether I'm in fair, moderate, or poor health. So the distribution of that health status, and then the factors that interact with or intertwine with how that distribution comes to be. And then lastly, in the platform is, what are the strategic interventions that we can take to improve those health outcomes? And so population health in itself is a concept, and how we manage population health is really the verb about going about instituting strategies and actions to address the health needs of a specific population. Taking that further, when you're talking about strategies and movement and doing the verb, we need to really understand in conversations with one another if we're talking about targeted population health or total community health. So targeted population health, or maybe intended population health, is really focused on improving the health outcomes and often reducing the cost of a specific group of patients or community members, often grouped by insurance type and really often focused on a specific chronic condition. So an example of this would be Medicare participants in your rural facility that are that have diabetes and that are actively seeking outpatient services within your facility. So very targeted group of individuals, are very, very specific. Now, total community population health is looking at the outcomes of an entire group of individuals in a community, often geographically defined, and then looking at the distribution of health status or outcomes within that group. So an example of targeted community health with that same concept I was talking about before could be diabetics, all diabetics in your market share area for your facility. So not just those that are under Medicare, which kind of often leads to a specific age group, or those that are seeking already outpatient services, but what is the population we could actually provide services to about diabetes. So, and the reason why talking about targeted versus community population health is important, not just to understand what one another are talking about, but really it ties a lot into resources. What's the time, energy, money that we're going to put into a specific effort as well. So why should a rural facility focus on population health? I think it comes down to really three kind of aspects. On the far left, it's often what our communities want. You know, the members in our communities and us as individuals want to be healthy in a way that health means to us individually too. We understand that it's not a unique one-size-fits-all definition, but a community desires for health. They're happy and proud to have a hospital or a clinic within their area, and they want it to be able to provide the services that help them to maintain health and stay within their area. On the far right of this graphic, organizationally, population health often aligns with the mission of our organization. I actually can't think of a rural hospital or clinic that I've worked in my 14 years here at the center that doesn't have something about serving the population, the community, health, well-being, caring for them as part of their mission statement. So it really aligns with who we are in rural. We know our communities, we intertwine with them, they're our family, they're our friends, and seeking to support their care and well-being is just part of the nature of what we do. Where those converge together about a community's desire for health and the organizational mission, as well as organizational operations, lands in the middle with value. And we're going to talk a little bit more about what I mean by value here in a bit. To kind of get us going, though, I want to share some examples of two communities here up front that we've been working with in our organization on population health activities. The ones that I'll be sharing do happen to be participating in a value-based model, but the things that they're doing aren't necessarily unique to having to be managing the risk of a population or participating in a value model. They're aspects that an organization could do on their own to work on either total or targeted community population health. So the one on the screen here first is Windham Area Health. That happens to be here in Minnesota, where I'm based. It's in Southwest Minnesota, so the corner near Iowa and South Dakota. And it's a critical access hospital. In that area, it's an expanding community. I'd say it's still kind of classic rural, older adults, but they're expanding with a large employer in the area who's bringing in younger families. And actually, it's growing the Latinx community in that area. So they started on a project with us on working to improve the health of a specific population in their area back in 2020, so pre-pandemic. And what they were looking at was they wanted to support the Spanish-speaking families or workers in their area that had elevated blood pressure and risk for type 2 diabetes, just to improve the communication with that population, seeking them to come into outpatient services to really help manage their well-being better. Throughout the pandemic and leading into the pandemic too, they had been talking about projects related to mental health, but really were not sure where to go. And as the pandemic really unfolded in their community, they saw really the arising and pressing need for mental health services. And they were talking with our organization about wanting to shift their project to mental health. And at first we're talking about just supporting those that were in the Spanish-speaking community as well. And then really decided to shift their focus that this could be open to any and all, but we do need to meet the needs of everyone and not just the classic approach of only English-speaking individuals being able to participate in services. So they completely pivoted the project in 2022. And now what they're looking to do is reduce the number of individuals that live or work in the Windham area or surrounding areas that present to the emergency department with a mental health or substance use issue. And what they've done is really recognize not only that was a need, but what's the circumstance in their community. So in that county, they have 750 residents to every one mental health provider. And unfortunately, that's not an abnormal story in many of our rural counties around the country. There's a huge deficit of mental health providers. Their neighboring counties in the area are just as much of a deficit. So it's not something they could outsource or really network on. But they decided that they wanted to tackle this issue themselves. And so in less than a month, they're actually opening a mental health walk-in clinic on May 1st. They've worked on setting up a business plan and billing. They've used a consultant to help aid them in getting those processes set up. And they toured some other area mental health sites in Minnesota and South Dakota to learn from them and their experiences. They've hired a therapist. It's a graduate social worker who's within 1 year of becoming a licensed clinical social worker. And they've taken 2 existing office spaces that they have that are relatively small, and they're converting those into their walk-in sites. But they do know that their facility in fall is breaking ground on a new expansion project that was already in the works. And in part of this expansion project, the walk-in clinic will move over to there. They're starting pretty small. It's going to be open only a couple days a week for a few hours, but they've been working with partners for outreach, such as the schools, the police, sheriff, a behavioral health task force, Kiwanis Chamber of Commerce, the large major employer in the area, as well as networking with other hospitals and clinics in the area, because it's a unique need that they can now fill in their community. So it's pretty exciting what they're doing with that, with taking and recognizing that they need to shift in order to fill the needs that are really present in the community. Another example to share, and closer to where all you live, is Caribou Medical Center, which is in Soda Springs, Idaho. This is another critical access hospital, and they had the vision that in Caribou County, they'd be supporting community members that were 65 years or older, potentially dual eligibles, to have fewer falls risks and falls-related injuries by maximizing their independent quality of life by creating a falls prevention program. So a small project really to get going, but what they're doing is in their emergency department doing an immediate assessment of a falls risk upon someone presenting there that could potentially be in jeopardy of something like this, and looking to have those processes all established by the end of this summer, and then trying to monitor then how those processes are being integrated into organizational workflow. They've been partnering with a variety of different partners there that you can just see on the screen to try to get the word out about creating a falls prevention program. And so individuals that are identified with them will be recommended over to this 6-week educational program that focuses on exercise and education. And they've been seeking volunteers then to help teach the program, and they're using their own internal employees that might be interested in volunteering, as well as high school students, and then peers that are also at risk for falls, for that peer-to-peer sharing that we know is a successful approach in many different things. Related to them being in an accountable care organization, they're also looping back in the opportunities when they identify individuals that are at risk for a fall to participating in the annual wellness visit, which is a billable service then through Medicare. So they're kind of taking together a population health project and then interweaving it into some of their value-based work. So to connect that together, what we're trying to do nationally as a country, and I'm speaking in generalities here, is to create a health system that links together healthcare with community organizations and partners to create a network of organizations that work together to improve population health. And again, as I say health system here, I'm not talking about being part of a system or affiliation in and of itself. I'm talking about a system as a country to improve overall healthcare. So I'm going to get a little bit into the weeds now about what some of these basics are of value-based models. But first, to kind of paint the picture about why this is happening and where it's going, is that we are moving into a system in the country, and we have been so for about 10 years now, of this need to demonstrate value. You've likely heard about the triple aim or even the quadruple aim, which was first coined by the Institute for Healthcare Improvement, and that's about better care, better quality, and better spending. The Centers for Medicare and Medicaid Services itself has identified its own quality strategy there on the screen that really aligns with the concept of the triple aim. And it can be described further into that formula that you see on the screen there in that yellow rectangle at the bottom, where we're looking to take the quality and the quality outcomes through measures and couple that with the experience of not only the patient or the family, but also the provider in satisfaction and experience of providing care and outcomes of care, divided by ultimately the cost of the care. And that itself is what equates to value. That's what helps the machine of healthcare, if you will, run efficiently and effectively into the future. But we know also that form follows finance. And so how we deliver care depends on how we're paid for it. And that's really the impetus for this large transition in value in the country. According to the Healthcare Payment Learning and Action Network, in 2020, about 15% of Medicare fee-for-service payments and about 39% of all types of payments did not have a link to quality or value. So there's been a big shift and a lot of work that's occurred since 2010 into this work, but we're still really at the Medicare fee-for-service starting line in critical access hospitals, rural health clinics and federally qualified health centers, and that's because of the mechanism to which we're paid really on the cost-based reimbursement structure, the fee-service structure. But we need to be kind of moving forward in this transition. So today at the top of the screen there, we're in this fee-for-service mechanism. We're paid for cost of units, paid for the production line type of approach and efficiency. We're not necessarily rewarded, unfortunately, for accuracy and outcomes. And this is, in fact, contributing to high costs of healthcare. And in many instances, I think it's also contributing to decreased patient satisfaction and likely provider satisfaction too, in this production environment, and not being able to spend the time or attention with patients as needed or desired. In the future, even now, we are in this transition to value-based payment, and this is where we're walking across this shaky bridge, and maybe you've heard this in LGB before. But in the future, we'll really be reimbursed and rewarded for better care, efficiency, and better outcomes of individuals looking to increase the healthcare quality, hopefully reduce the care costs, and improving that patient and provider satisfaction as well along the way. It's not an easy approach to accomplish, so I don't want to insinuate that at all. Rural health certainly has its challenges that I think many of us are familiar with, and nationally we know that there is, despite being in this fee-for-service mechanism, that is the aspect to which many rural facilities currently operate within. We had this enormous shortage of healthcare workers. This existed pre-pandemic. It's been exacerbated by that. We have limited broadband capacity in our facilities, but also with our patients and families trying to access their portals on phones and things like that, where the technology may not exist, or the broadband capability to do so may not exist sufficiently. And then we layer on that some social needs too, that can be even more specific in rural, where there's housing and transportation gaps. Generally, there is lower employment, income, and education, which is a disparity that exists in rural. We have a higher dependence on public programs, and we have higher levels of chronic disease in rural America compared to urban America. And then on top of all of that, we have the jeopardy of very thin operating margins within our rural hospitals and clinics, hospitals closing because of that, and the loss of some services that are actually keeping our younger families local. Younger families lend to vitality in rural communities for future generations, and they also bring in commercial payers that pay in a different mechanism than cost-based reimbursement too. A few years ago, the National Rural Health Resource Center, this was actually in 2020 and 2019, hosted a summit that was funded by Mayo. And what that was looking to do was to explore the rural health landscape and predict in 2030 what successful models of rural healthcare delivery would look like within rural Minnesota, taking into account the disruptors that we could predict now, that we could predict then, and that are certainly still a couple of years later actually really in play. So the discussion really focused on Minnesota, but the perspectives that were present were nationally representative, and actually I think the outcomes that were represented were national in scope as well. So through that event, we identified the series of disruptors that you can see here on the screen, that there are consumer-driven options that are impacting access to care, that we have dramatic and focused social investment occurring within our rural communities. We had increased really attention a lot in rural vulnerabilities that was exposed during the pandemic, that there's innovative rural population healthcare and payment models that were occurring then and are still continuing to almost even snowball now. That there was new technologies that were integrating into healthcare, including really optimizing the use of our electronic health records, for example. And that telehealth technology, payments, and regulations were enabling rural providers to interact virtually and differently with patients and communities than ever before. And so as we got more into that and could classify really what these looked like, we were able to interpret that things like improved access to care really aligned with some of the certain disruptors, and those included that consumer-driven access to care, that dramatic investment on social items, as well as the telehealth aspects. We identified that impact on affordability, of course, also aligned with that social investment. It aligned with new technology integration, and then also the payment reform recommendations and policy items that also too aligned with telehealth technology. And then lastly, the impact on quality aligned too with that dramatic investment on social items as well with the disruptors. And so it was very interesting as these disruptors came into play through this work with Mayo, that it ended up and the stars aligned with what is being described under CMS as their quality strategy, as well as their mechanism for how they're developing role models throughout the country. There's some basics to consider within value-based model and the building blocks that are really necessary for these models to be successful. As with any organization in any industry, leadership engagement is paramount. It's important for establishing culture. It's important for establishing vision and values. And without leadership engagement in any type of initiative, we do not see long-term success. Added to that too, I think, is also health equity. If we're not taking equitable approaches to things, we're actually not meeting our community needs where they're at. We're just generalizing to a part of the population. So health equity is a really important building block within the value-based models. And we're starting to see more emphasis come from the Centers for Medicare and Medicaid Services and how to address equity in payment mechanisms and in quality metric reporting that we'll start to see even more and more as years come. The rest of these are going up from the bottom are really in no other particular order. Patient and family engagement in the value-based models is really important. If you think back to that formula for value, quality plus satisfaction is really at the top. And that satisfaction is about that individual person, how their family may interact and advocate for their health care. And so their engagement in what we're doing is really important. We can, for those of you that may be providers, you know that you can talk until you're blue in the face about a particular health aspect to a patient, but until they own that or want to be invested in that or see that as a health priority for themselves, we're not doing anyone a service. So that engagement is really important. We'll talk a little bit later about why community partnerships are important, but essentially we cannot move the needle on health outcomes without others beyond just healthcare being a part of that. Team-based care, quality-focused care, and affordable care are all really important strategies as well in building blocks of value-based care in the future and currently right now. So to describe a little bit more about where, as a government, we're moving with value-based care, the Centers for Medicare and Medicaid Innovation Center is where the value-based models that are serving Medicare beneficiaries as well as Medicaid beneficiaries are being developed and rolled out through the country. They've done a variety of different pilot programs. They've done a variety of different non-pilot programs, kind of active programs. And from all of this, they're actively learning and engaging and developing new models into the future. So I want to take some time and describe the hexagons on the bottom of the screen there, which are those strategies, because I hope that they help you see what's coming and actually what's coming pretty soon. On the far left in the red one about driving accountable care, CMS is looking to increase the number of beneficiaries in a care relationship that focuses on quality and total cost of care. By 2030, their goal is that all Medicare fee-for-service beneficiaries and the vast majority of Medicaid beneficiaries are in a care relationship for accountability about quality and total cost of care. So that's just 7 years from now that CMS is expecting that all Medicare fee-for-service and the majority of Medicaid beneficiaries are participating in something. When we look at advancing health equity, their goal is to embed health equity in every aspect of CMS's Innovation Center models and increase that focus on underserved populations. That does include rural. And we're looking for their new models to require participants to collect and report on demographic data and social needs data, and to include in that patients that are historically underrepresented or underserved. And then also to address then what are the inequities and then how to address those. What are the targets for addressing those and to make improvements in the future. In the middle there with supporting innovations and the purple one is the light bulb, they're looking to leverage a range of supports that enable integrated person-centered care through a variety of different approaches, including peer-to-peer learning collaboratives and payment flexibilities. And they're looking to have target setting about improving the performance relative to desires and experience. And that includes things about patient self-reporting on things like health status and CAHPS scores. or CAHPS surveys. To improve access and address affordability, we've seen this in the recent past here with price transparency, but they're looking to pursue strategies to address healthcare prices more and affordability with that, as well as reducing unnecessary or duplicative care. There's another goal here too, that in 2030, CMS is looking to set targets to reduce the percent of beneficiaries that forego care due to costs. And from our work here in our organization on community health needs assessments, we do often see a percentage of our rural communities that are looking to forego care due to costs, because generally our rural communities are poorer than the urban environments. So that's certainly a concern too, and a disparity that exists. And then lastly, under partnering to achieve system transformation, CMS is really looking to align priorities and policies across itself, as well as aggressively engaging different payers and purchasers in states to look for equitable outcomes and reduce costs. So they're looking to really include multi-payer alignments into the new models that they're developing. So I want to back up a second. I know I've used the word value-based payment a variety of different times, so to talk about that and explain it in case you need a definition on this. But value-based payments a method, and I'm just going to read this here, but it's a method which purchasers of healthcare, so that includes myself as a consumer, it includes our employers who are purchasing healthcare for those that are employees of them, and it includes the government. So purchasers of healthcare and payers, either public or private, that hold healthcare delivery systems, physicians, individual physicians, clinics, hospitals, accountable for both quality and cost of care. So that's what value-based payment means. It rewards healthcare providers for keeping people healthy and providing care at the right for the right patient at the right time in the right place. But there's a continuum of different value-based payment models. So on the far left is kind of that starting line again, that's that fee-for-service area. And as we move right, we're into the pay-for-performance, value-based payment. Shared savings in purple is where we see accountable care organizations sit. And as we swing more right, then there are global budget capitation and then ultimately looking at total cost of care. So I'm going to touch on some of these here for a little bit more in depth. Under pay for performance or value-based payment, this is really those incentives. They really affect a small percentage of payments. It's really looking at still retaining some of that fee-for-service design. Examples of this that you likely are participating in are pay for reporting, pay for performance type of quality metrics. Under shared savings, though, like I mentioned, this is where we see accountable care organizations. So an ACO is a group of healthcare providers that take responsibility collectively for the cost and quality of care for a group of patients or individuals. ACOs and organizations that come together as providers to manage the care of those individuals do not need to be geographically located amongst themselves. They don't necessarily need to transfer physically patients among them. They're assuming the responsibility and the risk for this pool of individuals or patients. They're led by hospitals or physicians. They have primary care at their base, and that's why they are such a successful thing, or potentially successful thing for rural. It's because we do primary care day in and day out, and we do it really well. Under shared savings or an ACO type model, there's a variety of different ACO types, but if costs are lower than the target, the savings in our share between the provider and the insurer, and high quality is what you need to perform in to be able to have payment bonuses and maximize that payment incentive. We've seen a lot of rollout with the ACOs, and this has been going on for about 10 years now. This slide shows you where the Medicare Shared Savings Program ACOs are. The darker color is the more covered Medicare beneficiary lives. In 2023, there was 456 ACOs that were covering 10.9 million assigned beneficiaries. There are 467 critical access hospitals out of the roughly 1,300 or so critical access hospitals in the country that are participating in an ACO. There are 2,200 roughly rural health clinics and about 4,400 FQHCs that are participating. In 2021, there was a total earned shared savings of $2 billion with an average quality score of 91%. So they are demonstrating shared savings, and they are certainly demonstrating improved quality outcomes as well. There's a variety of good reasons why rural facilities should consider participating in a Medicare shared saving ACO. Essentially, they're lower risk opportunity for rural organizations to trial value-based care strategies. It allows you to network and aggregate across communities for scaled support, and to kind of normalize the data, if you will, by having so many covered lives. They're an opportunity for strategic investments that use advanced payments and other commitments. So you can build processes, you can build infrastructure for prevention, chronic care management, staffing to do such, care coordination, and integration of behavioral health. They allow us also to understand and utilize claims data to help manage care and predict opportunities to manage care in the future. And they also build that delivery system that can negotiate contracts with other payers, which is extremely advantageous. So I want to share a couple stories quick about some rural facilities that are participating in ACOs. This is just two that I grabbed information about, and they happen to be located in Illinois. I apologize for the really granulated picture here of Marshall Browning Hospital. It's a critical access hospital, like I mentioned, located in Illinois. There's a link on here to a video, and that's what I wanted to really share. But in a nutshell, this facility has gone through an important mindset shift from making people better, or making sick people better, excuse me, to what can we do to keep you well. And so they've implemented a transitional care model where upon admission into the facility, they're working right at the beginning about discharge planning, and not so much of hurry up and how can we get you out of here, but how can we maximize your care while you're here and make sure that you don't come back, because you likely don't want to come back to the facility after you've left. So it's really helped to improve their care coordination and reduce readmissions, and they have seen metrics to show that. They've involved the community into their support, and as such, they've actually rewritten their mission statement with the community at the center. So getting back to the heart of why the hospital was there to begin with. And they're working to get ahead of some of the chronic conditions with really a prevention focus. And they are participating in an ACO located in Illinois that is affiliated with a variety of different rural facilities there in the state of Illinois itself. So more of a geographic ACO that's affiliated with a large national rural ACO. Pinckneyville Community Hospital, also in Illinois, is part of that same ACO. But they have been working on a transitional care management program as well with a nurse, and they've demonstrated too reduction in readmissions. They've created some discharge medication instruction sheets and involved the patient and provider into those design. And as such, they've ended up being able to demonstrate improved patient and provider satisfaction scores about discharge instructions. They've also reduced their skilled nursing facility spending. And as they've been working on this, they've also been connecting further with the community and are starting to address other items that can or cannot impact that transitional care. But those include things like mental health, housing, and transportation. And they're doing that through using a community champion. A community champion is a really unique position. It's an individual that's employed by the facility itself, who interacts with the community to understand and help interpret what the community's needs and desires are. So as services are developed or under consideration by the hospital, that they are using the community's input into creating those and also creating community buy-in, as well as understanding what services are not necessarily needed anymore, so we can be operating efficiently and meeting the needs of our community versus what do we want to design as a facility. A community champion doesn't act as they're not the same as a community health worker. They don't have any interaction in individual patient care. It's more their representation of community back to facility and vice versa as a whole to improve overall community wellness. So pretty unique opportunity. So I mentioned kind of on that far right of the continuum of different value payment models, there are capitated payments and global budget. Real quickly, the Maryland total cost of care model has been one that's been going on since 2019. They have kind of three aspects that they're focusing on about hospital global budgets, so a capitated payment for that group, as well as looking to have a care redesign program, and then moving on the far right to focus on primary care to manage really best the risk of high risk individuals. They've added new providers into transitional care format, and they've been linking together disparate providers to help create more patient-centered or person-centered care. and then aligning their incentives across the providers to reduce hospitalizations and reduce total cost. So a pretty unique program, and we'll continue to monitor this. This one wraps up, I think, in about 3 more years. One more in tune with rural, though, is a Pennsylvania rural health model, where they're looking at moving from fee-for-service into this global budget. They're looking to improve quality and address community health. This has an interesting story with it, where the department announced this project in 2019 that had 5 hospitals and 5 payers that were participating in the program. And what this means, though, is that they are getting a capitated payment on a per beneficiary equation. So in 2019, again, they had 5 payers and 5 hospitals. And then the next year they added in 8 new hospitals. In 2021, they added in an additional 5 hospitals. And currently they have a total of 18 rural hospitals and 6 payers. That includes Medicare as well. So really, again, a focus on managing that cost. It's kind of like a salary where I know I'm going to get X amount per month for living. How do I want to make the best of my life with the amount of money that I have? So that's a very basic analogy, but it's similar to what they're doing with global budget. Then you have a capitated amount. How do you maximize care within that and efficiencies? A couple resources here for you from the Rural Health Value, which is a federally funded group that is looking at the rollout of rural models, supporting value-based care, what the outcomes of are those, and providing a lot of really great education. There's a catalog linked in here that's great if you want to dive into any more of the nuances of these different models, what they mean, and risk components and everything in that. And then some interesting information about an update that I'll talk a little bit about here with some rural changes that impact the Medicare Shared Savings Program. So a couple updates about things that have recently evolved. There is the Advanced Investment Payment Model. This was announced this fall. I have a typo on the slide here about the year. It's actually coming in January 2024. So CMS introduced some physician fee schedule changes to the Medicare Shared Saving Program to encourage participation, particularly by rural and underserved population providers. There's an upfront investment that's provided to the provider in this 5-year program. They get $250,000 in quarter 1, and then it's capitated quarterly per beneficiary payments through year 2. CMS is currently developing the participation requirements. We expect those to be out in the summer or fall. Again, participation starting in January 2024. It's kind of a loan money that you get, if you will, with the shared savings that you assume then you pay back onto that loan. It's really clear enough to present with confidence right now to all of you. If an organization that's participating, if they don't generate those shared savings within 5 years, what happens with that money? But there are indications that it kind of converts into a grant. If that's the case, it's very low risk. So more to come as CMS kind of clarifies a lot of what we're all questioning. An organization does need to submit a spending plan that's related to care coordination, addressing disparities, and things like that. More guidance is surely coming on that as well. There's a lot of interesting involvements happening with Medicaid that are developing and impacting rural, but there are 50 states with 50 different approaches to it. In a nutshell, though, they do have an emphasis on social determinants of health and integration and working with community-based organizations for partnerships. And there's a lot of movement in commercial ACOs too. We're seeing organizations like Blue Cross and Blue Shield and Cigna that are participating. We're also seeing Medicare Advantage as part of this too, because at the end of the day, Medicare Advantage really is viewed as a commercial payer, not necessarily Medicare. And in rural states like here in Minnesota, we have participation rates of 50 to 70% that impacts reimbursement then if those those individuals that are covered under Medicare Advantage cannot participate in a Medicare ACO, and some big question marks there. But what this all equates to is that rural needs to kind of continue to keep an eye on these evolving models and understand where the opportunities are to participate when they do present themselves. Again, the reminder that by 2030, CMS is really hoping that all Medicare fee-for-service and the majority of Medicaid beneficiaries are in some sort of accountability model where they are participating and their quality and their total cost is being monitored. So that is very quickly creeping up. I've kind of alluded to a lot of this during the presentation, but rural does have a lot of advantages with ACO participation, where we are this primary care-based operation to begin with. We have a lot of community focus, which also can help with that transitional care and care coordination, and that our systems can adapt more quickly than urban, and we've seen this time and time again for decades. There's been a lot learned through rural ACO participation. We've learned a lot about developing care coordination projects. We've learned a lot about behavioral health support and that hierarchical condition coding, which is being able to accurately code the risk of the individuals that you're providing care to, so that you are getting reimbursed for the level of care that's really needed to manage all of the comorbidities, for example, that they may have. So there's been a lot of lessons learned on that. Increased use of telehealth and technology was already becoming more prevalent and clear what the benefits were within the ACOs. So the pandemic on top of that, and the picture is really quite clear about the benefits of using telehealth. So there's been a lot that's been going on with rural ACO involvement over the last 10 years that shows opportunities and strategies for moving forward. So I'd like to wrap up here with talking about then how population health as a concept intertwines with the value-based models and the why of that, with social determinants of health, which I know I've mentioned a variety of times and haven't described exactly what that is, and also health equity. So social determinants of health, this is a great definition from CDC, and I think it's a powerful concept. So social determinants of health are the conditions, circumstances in which people are born, grow, live, work, age, and play. They're the circumstances that are shaped often by the forces that are outside of the control of the individual. They're things like economics, distribution of power and money, social policies, and they occur at the global, at the national level, the state level, and certainly at our local level too. And why this is important is that social determinants of health impact our ultimate health outcomes. And if we look at this graphic here on the left, this is from County Health Rankings and Roadmaps. At the top, we can see kind of the ultimate health outcomes are how long are we going to live and what's my quality of life going to be? And if we think about those things as our ultimate health outcomes, there's items down below that in blue that are the health factors that contribute into our health outcomes of length of life and quality of life. And in those things, you can see circled there clinical care. And we can say that clinical care, 20% of clinical care, things that we do about insurance, access to care, the quality of care provided, preventable stays, that clinical care aspect only contributes to 20% of our ultimate health outcomes. There's a whole host of other factors that happen. So the things that we really truly can control within our clinic and hospital walls impact 20% of the health and length of life of an individual. There's other factors that may be obvious, like health behaviors. If we choose to smoke, or how physically active might be. There's things like the physical environment. Am I drinking clean water? Am I living in a safe environment around myself? And then there's those social and economic factors like attainment of education, employment, income opportunities, that those are really where we end up seeing a lot of the social determinants of health play out. So that's why it's important to have other partners in supporting the health of our community and our patients. Health equity is a profound and important concept as well, and that's like the state in which everyone has a fair and just opportunity to attain their highest level of health. Not my highest level of health for you, but your highest level of health for you as an individual. That's really important. And in it, it looks at removing obstacles to health, such as poverty or discrimination, powerlessness, lack of access to good jobs, good food, whatever it may be, and making sure that there are equitable approaches. Equality and equity are not one and the same. On the graphic on the side there, and for equality, everybody gets a bike. That's excellent. Everybody has a mode of transportation and gets a bike. But everybody might not be able to use that same exact bike. Your legs may not reach the pedals. You might not be able to access or get onto the bike in the first place. And equity is giving everyone that fair and just opportunity for transportation on a bike with a bike that is suited for them. To achieve equity, we need to strive for innovation, and to do so, we need to have diverse voices at the table, and those at the table actually need to feel like they can contribute, are actually open and welcome to contribute in a meaningful way. And that's done through trust and empathy and cultivating those things, which is why a full community approach to items is important. Another concept you'll hear about are health-related social needs, and this shows up actually in metric reporting as well within population health and value-based care models. So health-related social needs are the unmet adverse social conditions that contribute to poor health. So housing instability is a health-related social need. A social determinant of health are the types of housing that are built in a community or zoned for a community. So health-related social needs, as you can see, there are a result of a community's underlying social determinants of health, and they can result in up to 50% of health outcomes. So there's different research on that, but they have a profound effect on health outcomes. And we can address health-related social needs through care delivery, quality measurement, and clinically supporting them through interventions. There's a link there to a screening tool that CMMI, Centers for Medicare and Medicaid Innovation, is suggesting is a standardized tool. So pretty important to start familiarizing ourselves with this. The other thing, besides capturing health-related social needs data from your community members, is also to understand how they want to be understood. So I encourage you in your organizations to think about capturing data related to race, ethnicity, and language, and sexual orientation and gender identity in a way that individuals in your community may want to report that. A reminder that race and ethnicity are really a social construct and a biological category, so that REL category system there that's hyperlinked provides you with other ways that individuals can use to describe themselves. And then the SOGI data is recommended, as you can see there, from the National Academy of Medicine and the Joint Commission as opportunities for individuals to better describe themselves versus kind of the standard female-male approach. So that's why hopefully you can understand that it takes a community to create health. It creates a community to create population health, and all those players are really important in value-based care. So when we're thinking about reflecting the health needs of our entire communities, we really need to have the entire community be a part of something, and we need to hear them all. We don't need to just hear from those that are in the position of making decisions or in power and leadership. We need to invite other community organizations to be at the table, and each of these organizations present here on the screen are great aspects to get into different parts of the community that you might not think of when we're even designing services to support them. There's a couple examples here in the slide set. I'm not going to get into them exactly. There's links on the screen that can tell you more about them. But it's an interesting opportunity that's been created here in Minnesota, North Dakota, Montana, and South Dakota with the Rural Aging Action Network to support aging individuals through a whole person lens. And then another Idaho example, but how a group in Idaho, at Pride in Idaho Care Neighbors, is working to support patients who identify as LGBTQ+ in rural communities, which is an aspect of our communities that is not well supported, generally speaking, in supporting their health outcomes in consultations with providers and in between providers as well. And our last little graphic to share with all of you here is about how we can meet in the middle for improved population health. And I just thought this was kind of a nice visual. If we're looking here at the stream, and you probably all have heard in various different conversations before about if we're upstream from an issue or if we're downstream from an issue. In healthcare right now, as we're looking to improve health, we're kind of downstream. We're at the end point of where health is happening with individuals generally coming for acute illness, but hopefully we can keep moving more and more upstream. We're also downstream more in the individual aspect, but if we move upstream with other partners, we get into more of that community impact for health and can cross sector to do work. And on the far right side of this screen, you can see where we can improve access and equitable care, referral networks, and working with community organizations. That's where that triple aim really comes to life too. So kind of a complicated graphic, but hopefully showing that we need to kind of, as healthcare entities, be reaching upstream more and fishing higher up in the stream to accomplish some of the big objectives that we touch on in our communities with our patients that we're serving, because they're not just coming to us for the ailment they may be presenting with. They have all these underlying things going on in their lives that we need to recognize that are being presented with as well. So again, a reminder that at the end of the day, our destination is this health system as a country that links together care with community organizations and partners to create this network to improve the population health that we're serving. It's not an easy journey to go on, but there are steps along the way and small aspects and projects that we can take to kind of keep moving forward and keep the momentum moving forward. My contact information is in here. I encourage you all to reach out to me, explore our website. We've got a ton of free resources on it too to help rural organizations like yours. And I'm happy to answer any questions you might have too.
Yay, awesome, Tracy. Thank you so much. Huge round of virtual applause for that amazing presentation. Thank you. We only have a couple minutes left. Tracy, do you have a few extra minutes to stay on?
Sure, I can do that, yeah.
Okay, awesome. So does anyone have any questions? You can raise your hand using the little hand raise button at the bottom, or you can put questions in the chat. Questions. Well, I have a question for you, Tracy.
Sure.
So I was wondering, how do you see value-based payments working for small RHCs that have relatively low patient volumes?
Yeah, so the value-based payment mechanisms within that are, it's part of being within a network. So not just how you interact as your own individual organization, but how can you maximize that work with being part or affiliated. And I'm not talking about you need to join a system like that, but being affiliated in some sort of shared savings program with other entities. That's the way to maximize really the cost savings is the larger the number. If you think back to maybe some classes that we had on statistics and things like that back in the day, the larger the number, the more noise you take out of the system. And so being able to think about how you best manage the care, where are the pain points with maybe your highest risk patients, and then being a part of a large group that can kind of help manage that volume of data and information to get you back to as a collective entity, then sharing that information. It's really nuanced into what type of model you're participating in. So, but in speaking in generalities there, that's kind of some of the formula for that.
Great, thank you. And we have a question in the chat. What are some examples of outcomes metrics associated with value-based models?
Yeah, sure, that's great. So at the end of the day, it comes down to the basics of like quality metrics and financial metrics. They're certainly what are being looked at. So there are specific set of quality metrics that are aligned with different value models. So maybe Steph, afterwards I could share you a link to send out to everybody about where to find that stuff. And then looking at, but I think one of the biggest ones that this is kind of a common thing, but looking at reduced readmissions is a huge, a very important quality metric in terms for CMS. But that also not only is about quality of care, that's about cost savings and things like that without redundant services. So there's that. There's also new quality metrics that are being folded in that are related to those health-related social needs and health equity. So there's a subset with that too that I can share along as well, and I could help give some examples of what some of those outcomes are. So those outcomes are all then tied into how do you roll those quality metrics up for improvement or decreased prevalence of whatever it may be.
Great, thank you. Any other questions from folks? Let's see. In the chat, do you have training addressing how best to reach rural communities?
Yeah, let me think here for a second. So, so in this slide set there, Jessica, there were some takeaways about some of the key lessons learned from ACOs. So I think those are specific examples. It depends on what type of facility you're talking about too. We have a whole bunch of webinar playbacks on our website related to finance and quality, particularly with value-based models, because we work in, there's other programs that we do at our organization that are federally funded that work with rural hospitals and rural clinics around the country that are specifically about the value-based transition. So there are some of those that are there. So I just encourage you really to go to our website, ruralcenter.org, and look around. You could, if you go into events on our website and go to past events, you can see a litany of different things there. And you'll find a lot of best practices there. We're not always the organization that provides that content. We work with a lot of other national subject matter experts to deliver that information too. So
Great.
I think that's the best place to go. It's just to look back through some of those that are about specific topics that you might be interested in, subtopics.
Great. Thank you. And just a quick note for folks, this webinar is eligible for continuing education credits. So I'm going to put the link to the survey if you want to get some CE for this. So fill that out. Yeah, so are there any other questions as we wrap up? It looks like that's it. Thank you, Tracy, so
My
much.
pleasure. Yeah, absolutely.
Oh, I really appreciate your time and expertise, and thank you to everyone for joining us. This was really lovely. I appreciate it. Awesome. Well, that our next webinar will be April 25th, so stay tuned, everybody.